What will be the next pandemic? I think one thing is for sure that it's probably not going to surprise us biologically, but it'll expose what we refuse to actually fix because pandemics don't come from nowhere. They're not Andromeda Straits. There are certain things, and I'll get into that, that help us predict what types of pathogens, viruses, bacteria, fungi, whatever it might be, can cause a human pandemic. It's really more about the tools. When you think about COVID-19, the last pandemic, the fact that a coronavirus caused a pandemic wasn't surprising because we'd seen what coronaviruses had done with mini pandemics or epidemics like SARS in 2003, Middle East respiratory syndrome around 2012. So we knew that these were viruses that should be on the pandemic list. So when a novel coronavirus found its way into humans and was able to spread efficiently, that's not biologically surprising. What was surprising was the mistakes that were made. The response tools weren't something that needed to be very novel, but they needed to be deployed effectively. They needed to be deployed proactively and rationally and competently. It's not about an if with a pandemic. It's about what breaks again when we have the first signs of a pandemic. So I think it's important to kind of reframe this debate away from what virus, and I believe it's viruses that are kind of the sole province of pandemics in 2026, moving away from what virus can cause a pandemic to what are the failures that will define it. And I think something that's key to keep in mind is that pandemics are much more about system failures than the individual pathogen that causes it. And I'll get to what pathogens I think are important to focus on, but the system failures often outweigh the impact of the pathogen. And I think it's really important when you're thinking about a pandemic or in the midst of a pandemic that certain things that the media might be obsessed about, like case counts, are given less emphasis versus things that are more important, like severe disease. Looking at infection curves is probably less important overall in pandemic management than looking at hospital capacity and understanding where the choke points are in hospital capacity. And I also think that there will be calls and talk about social controls, social distancing, mask recommendations, closures. That's less important than medical countermeasure development, which means vaccines, diagnostics, therapeutics. All of those are going to be important when it comes to blunting severe disease. We live in a planet that is dominated by microorganisms, and pandemics have been a part of the human story since humans lived in settled society. So I do think that it's really important to think about what matters when it comes to pandemics. And oftentimes people get distracted about minor things and not actually understanding the system that needs to be in place to be prepared. So when you think back to the last pandemic, what did we get right? Despite the disinformation out there, the rapid vaccine development, Operation Warp Speed, was an off-the-charts success. That allowed vaccines to be made against a novel pathogen, one not known to humans before 2019, in less than a year. So that ability is actually probably increased now since COVID-19, and there are pledges to develop a vaccine within 100 days. That, I think, is an underappreciated success story, especially underappreciated by the public, and it's actually been turned and twisted into something to criticize the pandemic response based on disinformation, but it is one of the major successes. So were the antivirals. We had drugs like Paxlovid that in the initial clinical trials were able to completely stop severe disease in unvaccinated high-risk individuals. We had diagnostic success. There was diagnostic mess-ups for a long part of the pandemic in the United States, but eventually we ended up with home tests. And the home tests for COVID spawned home tests for RSV, home tests for influenza, and home tests were, I think, an important part of how people learn to risk calculate and navigate in a pandemic. We also scaled up genomic surveillance capacity. By genomic surveillance, I mean the ability to look at sequences, to track variants of COVID. And we've also applied that to wastewater monitoring. So many municipalities around the country and around the world, they look for COVID variants, polio, measles, influenza, bird flu, antibiotic resistance genes, Mpox, other types of infectious disease. So this whole idea of using genomic surveillance of wastewater and other things, not just wastewater, but even, airport water, airport wastewater, I guess. And some people are talking about using blood banks. That's going to help us knit together a lot of information to get situational awareness of what's making people sick, what's circulating. But these are all necessary steps. And it's important that we have them in place for the next pandemic, but they're not sufficient. Because remember, the bottleneck wasn't the intervention. It was the deployment and the trust of the general public. And I think there are several things that we're still not ready for. I think number one, and I think this is a core failure, is hospital surge capacity. That means ICU beds, not just the physical beds, but the staffing, the supply chains for personal protective equipment, supply chains for mechanical ventilators, supply chains even for IV fluids. Those need to be fortified proactively ahead of time, not something that you're doing on the fly. Regional mismatch. Sometimes we talk about this as load balancing. So, for example, when New York City was hit hard in March of 2020, I was practicing in Pittsburgh and we barely had any COVID patients. So it's not always going to be a synchronous outbreak, a synchronous surge on the hospitals all across the country or all across even a region or even a state. And then even within a city, one hospital might be overwhelmed, another one might not be. And they might be from different systems. And they don't necessarily load balance, meaning one doesn't take patients from the other because maybe they're competitors and they want to keep things in their system. So that's something that's not solved yet. And I think that what ends up happening is you end up with this idea of treating hospital capacity as static, as some fixed thing. And it's not, but that's how people think about it. And they think of the pandemic as dynamic. And what you're trying to do is bend the curve of the pandemic or flatten the curve of the pandemic to get under hospital capacity with little concern for trying to increase hospital capacity. Why is that? Hospitals run, and we've talked about this just a minute ago, that hospitals kind of run near capacity. They don't really think about surge capacity as part of their day-to-day operations, and certainly not sustained surge. They don't necessarily always think of themselves in a regional or metropolitan area as a coalition, even though there's funding to develop healthcare coalitions. They have regulatory burdens like the number of licensed beds versus the number of physical beds. You might have union-imposed nursing staffing ratios. You might have reluctance to use hallway beds, even though there's good data to support the use of hallway beds. You have restrictions on hospital bed capacity expansion in some states through certificate of need laws, where competitors can oppose a hospital wanting to make a new wing, which I think is ridiculous. So it is a static quantity in one context, meaning that we made it static, but it doesn't have to be a static quantity. And I would also add that we have to think about crisis standards of care, that during COVID, a lot of futile care that was not going to be curative, care that just prolonged death occurred. And I think we have to have a discussion about futile care and not doing things that are going to be medically useless. And as part of that, we also need to think about, when do we go into crisis standards of care when we can't do everything for everybody? The other thing that it was important to think about is countermeasure policy. And by countermeasures, as I said, I mean diagnostics, vaccines, medicines, including monoclonal antibodies. So the fact that we have a lot of vaccines that are made doesn't actually turn into vaccines in arms. So that last mile is really important, making sure that countermeasures actually get to the people and are used. So that means vaccines in arms, that means antivirals in people's stomachs, and it means that diagnostics are connected to action, that people know how to use a diagnostic to guide their day-to-day life. So that's kind of the last mile, making sure that you can do this. If you've got vaccines sitting in a storage warehouse or at a pharmacy that no one goes to, or in a place where the disease is not, meaning that they're not being used impactfully, that doesn't help you. So we have to think about that. And there are innovative stories from COVID about using zip codes and understanding where disease burden was the highest and making sure countermeasures got there, that there were telemedicine connects so people could get prescribed antivirals. And they actually utilize some of this with Mpox. Or here in my home city of Pittsburgh, they're doing pilot programs to do hepatitis A vaccination by paramedics, by EMS, in places that are hard to get to, that don't have access to the hepatitis A vaccine. But the point is, no matter how incredible your tools are, you've got to connect them to real world decisions. And that's going to be part of how we prepare for the next pandemic. Risk communication and public trust is another major component. That's something that is 5 lectures in and of its own. I think what ends up happening is people overpromise Sometimes people drop nuance. People like this whole duck and cover thing that we used to do for nuclear preparation, and they like to extrapolate that in places where it doesn't belong, which is an evolving infectious disease outbreak where the science is being added to every day, where the context is changing. That all needs to be communicated, even if some PR person tells you we want simple and quick and one size fits all. That builds mistrust. You need to have nuance. You need to protect your credibility by being nuanced, saying, this is what we know now. This is what we don't know. This is what we're doing to find out what we don't know. And this is how things change if we find out something that we don't know, so that people know that this is an evolving process. It's not flip-flopping. It's an active mind struggling with increasing data and trying to interpret it to make the best policy. It's also true that we can't just be tunnel visioned in short term only. You cannot sacrifice the long term to the short term. They should be integrated. And that's where policymakers have to make those decisions. If you ask an infectious disease doctor how to do something, they're going to say, this is what you would do to get this many cases. This is what you might do to get this many cases. The policymaker has to understand what is sustainable, what fits with their duty to protect individual rights, and they have to not abdicate that. But unfortunately, they often abdicate because they don't want to be blamed. And they also want the imprimatur of science. They want this whole scientism thing when it's convenient to them. And remember, it's not up to the infectious disease doctors to weigh all of the policy things that go on down the road. What's that going to do to the dollar? What's that going to do for world trade? What's that going to do for XYZ? That's the policymaker. That's what they're elected to do. They can't abdicate all of that to an infectious disease doctor and then shift the blame to an infectious disease doctor if things don't go the way that the population wanted. People can tolerate risk. They're mature, they're sophisticated, but what they can't tolerate is inconsistency and paternalism. So I think that's an important point. Policy overreaches versus precision. I'm always someone who advocated from the very beginning precision-guided public health interventions. You can't treat the entire population as the same. Some people are infected, some people aren't. Some people are high risk, some people are not. Some people have different value hierarchies. It may be important for them to do something and less important for somebody else to do something. So blunt tools such as shutdowns, lockdowns, school closures, I was never in favor of. I understand why governors and mayors and school boards did it. They were scared, and there was so much inaction through January, February, and half of March of 2020 that the time to use precision-guided tools quickly ran out, and blunt tools were all they had, especially in that context. But what we really should strive for is to be proactive, so blunt tools aren't the only option that governors see. And I think we know, for example, with COVID early on, that this impacted the elderly, particularly nursing home patients, much higher. Why weren't nursing homes fortified in January, February, or March? Why were there kind of crazy policies to send contagious people to nursing homes in states like New York, New Jersey, and my home state of Pennsylvania? This just kind of defies logic. And if you take away nursing home deaths from COVID, that's a significant percentage of deaths that you're taking away, which is why there was some controversy over this in New York State when the then governor was trying to move data from nursing homes to hospitals. So what does the next pandemic look like? It is going to be a respiratory virus in my mind, and it's going to come from one of 5 or 6 different viral families that I've outlined before. And it's likely going to be something, so it's going to come from a viral family. Let's just take, for example, the orthomyxovirus family. Orthomyxoviruses include influenza. So it doesn't mean one of our seasonal viruses that's circulating is going to turn into a pandemic strain, but what I think will happen is an adjacent virus in animals, particularly in birds, is going to develop the capacity to spread from person to person. Just like SARS-CoV-2 came from a known viral family that had respiratory viruses in it that could spread efficiently between humans, one of its cousin viruses that was circulating in bats found its way into humans. So it's my hypothesis, my theory, that respiratory viruses are kind of the province of pandemics. Why respiratory? Because if you can transmit something when you're talking, laughing, coughing, sneezing, breathing, something that spreads through the air, it's very hard for public health interventions to stop it, as we just saw. And then amongst those pathogens that spread through the air, viruses are the most formidable. And of those viruses, there are certain families, like the coronavirus family, like the influenza virus family, which is known as orthomyxovirus, like the picoRNA virus family, that includes things like common cold-causing viruses, like the pneumovirus family that includes metapneumovirus and RSV. The adenovirus family is one that I also put up there as well, which includes a lot of the common cold causing viruses and sore throat causing viruses, and the paramyxoviruses, which include things like measles, which include things like parainfluenza, and things like Nipah virus, which is a dangerous zoonotic disease from bats. So I have certain viral families. So I think that's likely where the pandemic is going to come from. And I've done some work trying to do that. And many of these pandemic viruses, if they find their way into humans and spread efficiently, they're going to be destined to become endemic viruses. The way that 1918 avian influenza became an endemic influenza seasonal virus, or the way SARS-CoV-2 became our 5th seasonal coronavirus. That's inevitable. So there'll be talk about eradication and things, but that's not necessarily what's going to happen, because it's almost always going to be the case. At least I think it would be. I have to challenge my own thinking on that it will become an endemic respiratory virus afterwards. So the real risk is really, to summarize some of what I've said so far, is going to be, there's going to be misaligned incentives, short-term versus long-term, trying to stay in office for elected officials, for example, politicized decisions, because everything is tribal politics now, and delayed use of tools, meaning there's going to be inaction. People are not going to be proactive. They're going to take action too late, most likely. And I think the biology is not going to change. And I don't think our mistakes are going to change either. But the biology is something we can't really change, but our mistakes are something that we can change if we take the correct actions. What are some things that I think we need to do? We really need to get hospital capacity fixed. We have to build flexible hospital capacity. We've got to make that something that's valued by hospital leaders. We've got to make something that's valued by politicians so that they remove the policy and bureaucratic barriers that hospitals face. We have to continue to invest in platform technologies for vaccines, antivirals, and diagnostics. And here's a place where I think artificial intelligence can help. And I've done some work on the use of artificial intelligence in medical countermeasure development, recently published in the journal Open Form Infectious Disease. We have to think about risk stratification, value hierarchies, nuanced communication, and we have to communicate uncertainty very honestly with people. Those are some things that we need to do, but overarching is that we have to get this policy set up ahead of time, and we have to make it prioritized by policymakers who might only be thinking in 2-year and 6 years and 4-year cycles, and not thinking about pandemics the way they think about other national security threats. To close, I want to say that the risk, it can never be zero. There's always going to be some risk of pandemics so long as humans interact with each other. And that's especially true with respiratory viruses. The goal really is to make sure that when the next pandemic comes, it doesn't collapse our hospital systems, doesn't put them at the brink. And I think that's what I really focus on, is not so much the prevention of pandemics completely, but being able to intervene early enough that severe disease does not become too hard to handle. So just remember that preparedness isn't necessarily about completely stopping the next virus from finding its way into humans. It's about responding to it intelligently using our full human capacity. And I hope that helps you think about the way I think about pandemic.